Grainger CAN drop box. So the agenda today will be a series of speakers. We'll start with Walt Vernon, then Tracy Hennigan, and then Stephanie Taylor, and I'll introduce them in just a minute. And then after that, we have an open time for you to ask your questions and just to have a discussion about this topic. We've got the meeting scheduled for 3 hours total, but it doesn't have to last that long, but we wanted to make sure we had time for the speakers and also plenty of time for you to ask your questions.
Hey, Don.
Yes.
Don, may I rudely interrupt you? Would it be okay with you, because Tracy and I talked about this, but could I go after Walt and then Tracy, because I don't have any real expertise on how to implement some of the suggestions. And so in my experience when Tracy and I work together, she's able to, put the real worldness to what I say. Is that okay with you, Tracy? You and I talked about that. Thank you.
Yeah, that'd be great, just as we planned.
Sure, that's fine. That's fine. For the Grainger CAN members at the end of the meeting, we'd like you to stay on so we can just talk about next steps and set up the next meeting. So without further ado, let me go ahead and introduce the speakers, and then I'll turn it over to Walt because I know he needs to leave briefly for another meeting. I know some people have to kind of come and go, and that's fine. I think we can manage all of that. Let's see. All right.
You're muted, Walt.
Well, hold on just a second. Let me
I'm sorry.
Yeah. And we don't have time today for everybody to really introduce themselves. So when people ask a question, if you wouldn't mind just introducing yourself and what system you're from or what organization you're from. We have a variety of different people from VPs and directors of facilities from different health systems across the country. We have staff from the Center for Health Design, and we have staff from Grainger. So we have a nice mix of people. So let's start. Let me introduce Walt Vernon. Walt is a dear friend of mine. He is the CEO of Mazzetti, which is an engineering firm with offices across the country. And Jim Crabb, who you heard from last week, is a principal at Mazzetti and has joined us again today for the question and answer period. Walt has experience in the design, planning, and construction of healthcare facilities for over 30 years and is very passionate about the environment and is in fact actually chairing a committee right now on climate change with the World Health Organization, and he can tell us more about that. He's also was one of the co-authors of the Green Guide for Healthcare. He sits on the FGI Healthcare Guidelines Committee, Research and Guidelines Committee. He also is a member of the Center for Health Design's Research Coalition and our Built Environment Network, and also for ASHRAE is the vice chair for the ASHRAE 189.3. So that's Walt. Let me introduce all three speakers and then I'll turn it over to them. So Tracy Hennigan is a principal and mechanical engineer at Hoffman Engineers, and Tracy, like Walt, has managed many complex healthcare projects from concept through construction, and is a fellow at ASHRAE, and is a frequent speaker and talks about the impact of outdoor air, hydration, and its impact on occupant health and the spread of infectious disease. And then Dr. Taylor is the CEO of Taylor Consulting, and Stephanie is a physician who obtained her degree from Harvard and worked many years as a physician, and then became really committed to wanting to look at the environment in a different way. So got her master's in architecture and a certification in infection control. has a real commitment to looking at the impact of balancing outside air, temperature, and humidity. And so, and will give us her point of view about how to look at all three of those things. So I think we're going to have a great panel today, and thanks, Jim, for joining us as well. And so, Walt, I'm going to turn it over to you to kick us off.
Okay, thank you, Donna. And I do apologize. By the way, you mentioned that this climate and health thing was WHO. I did do a project with them on that topic, but this one is actually with the National Academy of Medicine.
Oh,
And
sorry.
I'm not planning to talk about it, but I could later if you guys wanted to. And I have to apologize because I got double scheduled for this meeting and a meeting of the National Academy. So I'm going to present, go to that meeting, present, come back here, answer questions, go back there and answer questions, I think. So wish me luck. So today, I thought what Donna asked me to talk about was the ASHRAE infectious aerosols position document. You are maybe familiar with that. I think we sent a copy of it out to everybody. It's a recent publication by ASHRAE. And I think it's pretty important. I have been involved with ASHRAE for a long time in various ways. And I have not before worked on a document they called a position document. And a position document's a little bit different from other kinds of documents that ASHRAE publishes. ASHRAE tends to publish things that are model codes like ASHRAE 170, which you all probably know and love. They tend to publish guidelines, and I guess I would frame it as maybe best practices, handbooks, references, how-to sorts of materials. Position documents are a little bit different in that they try to summarize the science that surrounds a particular topic. And I've had to learn all this very fast, as you might imagine, because I've just sort of newly been put into a position. But to summarize the science and position of ASHRAE with respect to where ASHRAE and the world need to move with respect to particular issues. I was privileged to be on the committee that wrote the current document, which you all now have. And in that process, one of my co-panel members was talking about, he had been on a position document earlier that was talking about smoking and how we should ban smoking from buildings because of the interface with ventilation systems and human health. And so that's sort of the significance in a way. It wasn't a code, but it's sort of early on in the smoking debate created a position that said we should do something. So anyway, it's a really interesting kind of a process. What I did want to, before I sort of dive into where we are with the position document and what you need to know about that, I wanted to reflect actually on a different study that ASHRAE did together with ASHE and the FGI, probably finished up a couple years ago. Those three organizations came together and said, listen, we have this document, ASHRAE 170, and most of medicine, well, I won't say that. Let's just say that in medicine, there is increasingly an idea that we need to be doing evidence-based measures and really hewing to the science and making sure that we are, our interventions are effective. And so this whole school of thought around evidence-based medicine has developed. And ASHRAE, FGI, and ASHE thought, well, in some respects, if we're saying the ventilation systems in buildings are contributing to prevention of infection, possibly, in some senses, the building is becoming a medical device. And maybe we should start to think about the building as a medical device in a way that's similar to the way we think about other medical interventions. And so ASHRAE, to its great credit, I think, undertook an effort to go through the requirements in ASHRAE 170 and to look at each requirement And is there any evidence for this particular requirement? It was a fascinating study. It's available on the ASHRAE website, but they were able to validate a number of things that we sort of intuitively believe to be true. I don't think that there was anything that we found that needed to be, that was definitely wrong, but there were a lot of things that needed further exploration, of course. But I think it was a really, really important step for ASHRAE. Actually, I have to say, when I came to ASHRAE as FGI and said we should do this, you know, at first there was kind of fear about, well, we don't really want to expose the fact that we may not know anything about why, you know, these are requirements are there. But I think to ASHRAE's credit, they thought, no, we need to do this. And they did it, and I think they did it well. And I think it's helping to inform a research agenda that's now helping ASHRAE continue to ask deeper questions and really bring to bear the science. So the infectious diseases, or sorry, infectious aerosols position document, in some ways was a next step in that process a little bit. I don't know if any of you have looked at it. So I was appointed to this committee. I was actually appointed rather late in the committee's work to replace somebody who dropped off. And one of the things that we were struggling with on the committee was to try to express the level of certainty or uncertainty around different knowledge pieces and recommendations. And we would have these lengthy debates about wordsmithing about our level of certainty. And we would say, well, we don't really know much about this, but we know about as much as we know about this other thing that we don't know anything about. And so maybe it's okay. It was getting really, really difficult to express how well did we know something. And so I, at that point, said, well, let's reach into the evidence-based medicine bag of tricks and see what's there. And in the evidence-based medicine world, they have something called a SORT, a strength of recommendation taxonomy. And I'm not going to explain it too much, but the essence of it is it tries to look at how strong is the science for a particular bit of knowledge, and how effective is this particular intervention, particularly in the context of trade-offs. And so based on that, it then will tier recommendations to say, we have a lot of science, this makes a lot of difference. And so therefore, this really is important for everybody to do. Or we don't have much science, but it looks like this would be really good, or whatever, right? There are different levels. And so we tried to bring that way of thinking to this question about how do we use ventilation systems to mitigate the risk that comes from infectious aerosols. So I think we did it, we were struggling through that process and trying to figure out how do we do this well. Partly we were drawing back on the previous work that I mentioned that ASHRAE had done, doing a deep dive into the research. And then the virus hit, right? And all of a sudden there was an urgent need to put something out that would be helpful based on at least what we know now. And so there was a very hectic week or two with all kinds of, I spent more time on conference calls and looking at COVID research than it was sort of an amazing time. And then the ASHRAE process has multiple layers of approval, most of which I still don't understand, but we went through all of that somehow and published a document that I think all of us knew was probably less than perfect because we needed to get something out there. And so I would never claim perfection with what we issued, but I think it was an important step forward, in particular in using this SORT methodology. So I want to talk just about a couple things in the current document, and then I'm going to talk about where we're going, all of which I think is important for you to know. The first thing that's important to know, there are a set of recommendations based on our sort of findings about the evidence. And the first, I think, really important recommendation in the document is that infectious aerosols are not confined to healthcare buildings. You're in a healthcare audience, but most of you probably manage much more in your portfolio than just hospitals, right? You probably have ambulatory surgery, maybe some other outpatient, maybe labs, maybe warehouses, maybe office space, whatever. Well, somebody with the COVID virus could walk into any of those spaces, and there is risk that has to be managed. And so the first thing that we recognized in this is not a healthcare issue. It is a healthcare issue, but it's an all space issue. And that makes it a little tricky, because then you have to measure how much risk is there in what kinds of spaces, and then which kinds of interventions are really appropriate for which kinds of spaces. And again, this is a position document, not a code, not a standard. I'm not trying to tell people what to do, but the conclusions were that we know with some level of certainty that certain interventions have more impact than others, maybe I would say, on mitigating risk of transmission. And we can talk about chain of infection and all those things if you want to. But what we tried to say in the document was, look, anybody who's building a building today, schools, right? This is a big deal right now. How do we open schools? How do we send people back to offices? Any of these buildings has the potential for risk and needs to think about, if you will, the ventilation bag of tricks that we know have various impacts, and think about which of those might work given your risk level. And I'll say one more thing about that. I was on the ASHRAE committee that wrote the Legionella standards. And when we talked about healthcare in that context, we really tried to make it a risk-based strategy, because water quality is different in different places. Susceptibility is different in different patient populations. Community risk levels are different in different populations. And healthcare, unlike other buildings, has typically on-staff risk management people, epidemiologists, public health people, whatever, right? And so we wrote that to say, listen, rather than trying to create a one-size-fits-all prescriptive path, what healthcare should do is do a risk analysis and look at your own risk and look at the available tools and use the tools that are most appropriate to your situation. And in some ways, that's what this infectious aerosols position document tried to do for all buildings. Again, wildly imperfectly, I'm sure, but that was the intent. We've published it. We're now getting comments, and there are other groups that I'm sure Tracy and Dr. Taylor will talk about within ASHRAE that are doing other things and receiving some of the feedback. And it's clear that we need to do an expeditious rewrite and update of this document. So I was honored to be asked to chair the rewrite committee. And I feel a little bit like I've got a tiger by the tail, but I'm working on it. And one of the things that has happened, you guys may have heard recently about the World Health Organization coming under some criticism for their thinking about COVID in particular as an infectious aerosol. Coincidentally, I was doing work with Jim with the World Health Organization on COVID facilities, and they are really working hard to try to figure out what to do. And they've got a whole infectious diseases transmission committee. And because we were connected with them, I went to ASHRAE and said, listen, WHO is doing this and we're helping them do this. You're doing this, trying to help you do it. Why don't we put us all together and do this once? Because the infectious aerosols thing is not confined to one country or another. So anyway, in process right now, a collaboration between WHO and ASHRAE to publish this next version of the position document. And I could, I'm going to have to bring this to a close here in a second to get to my other thing. But the other thing that I would say, a couple of other quick things about that, you know, there's an urgency to this because of some of the feedback that we're getting from the field about the document itself, and we want to address that. It is likely that we're going to construct this with a single voting committee, mostly composed of scientists, but we're looking at infectious diseases experts, certainly ventilation experts, public health experts, other kinds of, we're going to include the fellow, the PhD who did the work on the previous study, so he has at his fingertips the best evidence. And then there'll be probably an advisory committee from ASHRAE, because there's limits on how many people can be on the voting committee. So we're going to have an advisory committee from ASHRAE, an advisory committee from WHO, and hopefully we're going to do this in a timely way. As I say, I have a tiger by the tail. And two of the other requests that have come up that I'm now haggling with ASHRAE leadership about, there is an urgency to open schools right now and other buildings in the face of this corona situation. And so there is a desire that the infectious aerosols position document is not confined to healthcare, and it is not confined to COVID. It is intended to address essentially any infectious particle, I suppose I would say, that might be transmitted through aerosols, which, you know, the vocabulary Jim, I think, explained last time. So hopefully you all understand that. And so there's a desire to write something very particular for both WHO's perspective and other members of my panel with respect to COVID as some sort of an annex or position, you know, supplement to the position document. We're trying to figure out now, what does that look like? And the other thing, because now WHO has gotten involved and because ASHRAE is an international organization, we want to look at ranges of resource. That is to say, Jim, and I don't know if he talked about this before, but he designed with the WHO a hospital in Burkina Faso, Africa. It was a COVID hospital. And needless to say, in Burkina Faso, they do not have available to them the technology, I won't say the technology, let's just call it the money, frankly, to do the same things that we would do in a hospital. And so we were forced to do something different and creative. And so one of the things there's a heavy hunger for is, how do we state these principles and give guidance at various resource levels, if you will, so that we can be relevant in a variety of circumstances. So that there's potential for a second kind of spin-off document focused on that. And so maybe that's enough about where the position document is headed, because I need to stop here.
Yep.
So
Yep.
I'm
Thanks,
handing
Walt.
the baton. Yep, I'll come back and answer questions later. So thank you, guys.
Great. Great. Thanks, Walt. Okay, Stephanie, do you want to go ahead and go?
Yes, so I'm going to share my screen. So actually, Walt, can you hear me? Is that good?
Yes. Yes,
Okay.
we can.
So Walt, that was an amazing explanation of sort of the shift in thinking in ASHRAE. And I love the way you brought in the concept of evidence-based medicine. And now, you know, thinking about that same strategy for understanding the connection between the indoor environment and human health is perfect. Because in medicine, you know, we used to, I mean, I'm not talking about bloodletting. I'm talking about more sophisticated disease treatments from bloodletting. But we used to do things that were sort of based on our intuition. For example, we gave women hormones after menopause, thinking that some of the diseases that increased after menopause were due to a decrease in estrogen and progesterone. Then we did an evidence-based study where we used double-blind prospective cohorts of patients. And we didn't have an expectation. We just were trying to figure out, is this good or bad? And when the data was cracked, we learned that not only did postmenopausal estrogen and progesterone not protect from the things we were hoping it protected us from, but it actually caused an increase in some diseases. So relying on our intuition, it can kind of give us a start, but we really need this concept of evidence-based design. So I love that. So for my part of this, I say the building will see you now, because I believe that the future of public health is really in the hands of building professionals, engineers, architects, infection preventionists, but it's really the built environment that's key to protecting human health. Because as a physician, I can say we've kind of made a mess of things. You know, we get paid for taking care of sickness. We like to charge for whatever we can charge for, and that usually doesn't really optimize prevention and wellness strategies. So for those reasons, plus the importance of our environment, building professionals, in my opinion, are really key to the health of our population. So I say, hi, this is me, if I were in my patient mode. So moving along, what I'd like to talk about in the next few minutes, forgot to start my timer. So COVID-19 has really been a wake-up call. And from one perspective, there's the silver lining, which is in the course of a few months, we've really turned our focus onto how buildings can protect us. And instead of having that change in attitude limp along and maybe evolve over the next 20 years, it's happening very rapidly right now. So I'd like to acknowledge that. I'd like to take you through a couple studies on human beings indoors, because as Walt said, you know, we're not always in a hospital, and yet the building is going to impact us when we're in a hospital or we're in any indoor setting, which is where we spend most of our time. And then make a plug for how buildings must and support healthy occupants, but I know that I'm preaching to the choir on that. So before I get into my presentation, like the meat of it, I just wanted to let you know how I, as a physician, really started looking at the environment. So this is me a while ago when I was in medical school, and I wanted to have an adventure, so I went to Papua New Guinea to practice medicine for 4 months. And that photograph on the right is the first injection I ever gave anyone, and I think that woman knew it. But I had an incredible adventure. And this is the hospital that I was stationed in, the WEWAC General Hospital. And you can see the conditions in this hospital weren't what we're used to seeing in this country. On the right, that's me in the operating room, sort of looking astonished at this patient who was about to have surgery. I have flip-flops on. That was the footwear of the operating room. The surgical nurse did not have gloves on. So you can see, you know, very different conditions. And yet, these patients did well. They didn't get infections. They didn't have the rate of nosocomial or healthcare-associated infections that we see in this country. I didn't really think about it at the time, but I thought about that later, and I wondered, well, why was that? And also when I was in medical school, I was doing research on melanoma metastases, and my mentor was Dr. Folkman, brilliant, wonderful guy. And one night around 11:30, I realized that a lot of our mice were dying, control mice, study mice. I called him up, I'm sure he was asleep, and I said, something's going on. He came into the lab and we scrubbed the research operating room down from top to bottom. And Dr. Folkman told me, he said, never ever underestimate the power of the environment in clinical outcomes, whether you're a mouse or a person. So fast forward to my practicing pediatric oncology, I began to be aware that the building might have a role in some of my patient infections. And yet, as a physician, I tried to talk to the building facility managers, and I didn't understand them, they didn't understand me. My physician colleague said, just, you know, wash your hands and don't pick your nose and give the right antibiotics, and that's all you can do. But I wasn't convinced. So that's why I went back to get my master's in architecture to have a better understanding of the building. But speaking of environments, you know, if we go back through time, you know, quite a while ago, even longer ago than when I was in med school, we lived in dwellings that were really open to the outdoor environment, air, soil, plant, animal material. And our building technology and materials became more sophisticated, and, you know, we developed these amazing sanitation and hygiene systems. By the Industrial Revolution, most of us were working indoors unless you were in agriculture. And then fast forward to 2020, you know, a lot of us work, or before COVID-19, worked in sealed buildings. A lot of the windows are not operable. Indoor conditions are comfortable. You could go to work in bare feet, even in the winter if you're allowed to. So we've made remarkable progress in the sophistication of our buildings. However, unfortunately, several categories of diseases have dramatically increased. Some infectious diseases, autoimmune disorders, inflammatory-based disorders. And so even though this isn't a statistically relevant table in front of you, it's showing a relationship that we need to take a look at. So, right now we're still in this COVID-19 pandemic. It's not the first pandemic, it won't be the last. The three depicted here are all caused by the same family of viruses called a single-stranded RNA virus. And this is actually pretty relevant because single-stranded RNA viruses, such as the coronavirus family, which SARS-CoV-2 is one of, they mutate rapidly, more rapidly than any other family of viruses. And so all of the pandemics, and probably the ones in the future, will be based on these single-stranded RNA viruses. The reason they mutate so quickly is that when these viral particles replicate, they don't proofread their offspring. It's kind of like my son in the 8th grade. He'd write a paper and there was no concept of proofreading and correcting mistakes. He would just send it off to get a C+. So that's what these viruses do. But the consequence of this sort of careless replication is that new strains are formed. And if one of those new strains finds an environment that was previously uninhabitable, but now can be inhabited by this new strain, they have an environment with no competition. And if they find a host, such as the human being who has no prior exposure to this strain and therefore no immunological defense, what happens? Well, a pandemic is what happens. So this virus mutated in several ways that make it difficult to control. We can be infectious before we're symptomatic. It attaches deep into our lungs. So often people present when their illness is at a pretty scary place. So let's just take a look at this whole idea of microbes and human beings indoors. This is a short video. So as I'm talking, droplets are coming out of my mouth. They carry all of the bacteria and viruses, good and bad, that are in my mouth, my nose, my sinuses, my airways. Everyone, I hope you're still breathing. This engineer is working away, or architect. She's leaving her skin particles on the table. They carry the normal Staph aureus that's on her skin, the yeast organisms, all of the normal flora. They're coming off of her skin in particles. You'll see droplets coming out of her nose. Those aren't liquid, those are just particles. Her GI tract is illuminated because we have a lot of organisms in our small and large intestine. Those who have a gas problem release those into the environment. And you can see as she deposits all of these organisms on surfaces, there's a lot of communication between air and surfaces. We live in a three-dimensional world, so that's really not so surprising. And then depending on how your building is operated and designed, you'll have more or less communication between indoor and outdoor air, particles, and microbes. So what we have found using a new set of tools, so moving from solely using tissue culture tools where we evaluate the organisms in a building and those organisms' relationship to our health using things we can grow in a petri dish, we now have the capability of looking at the DNA and RNA fingerprints of all of the cells, the eukaryotic cells, the bacteria, the viruses in our bodies, on our bodies, and in our buildings. So this is, in our bodies, it's known as a human microbiome. So it ends up the buildings have their own microbiome. The picture on the bottom of this slide shows that, this is from the University of Oregon. Depending on how a building is designed, ventilated, and used, certain organisms are going to survive. So that what this means, and this is so powerful for building professionals, anyone in the design, operation, maintenance, the indoor environment not only directly affects our health, but the indoor environment is now selecting the microbes, the good ones called commensals and the bad ones called pathogens that are going to persist in the indoor environment. So buildings have sort of become like the evolutionary force for human beings. So let's take a look. I just want to go through 3 studies to take a look at using an evidence-based design approach. How do we know if what we're doing with building an indoor air management, surface material selection, spatial design, how do we know if what we're doing is right or wrong from the perspective of health? So I was in my infection control role with hospitals. We were using different surrogate measurements for the presence of microbes, things like Petri dish techniques, ATPase wipes, particle counts. And it occurred to me one day that why don't we just use the most specific and the most sensitive biomarker of a good hospital room. I thought, and that's really the patient. Why don't we use patient outcomes to assess our buildings, to tell us our hypothesis right or wrong? So with that kind of mindset, say this person has the bad manners to walk into your house and cough, and she's not wearing a mask, and you can see if she has COVID-19 and they're in these droplets, they're spewing forth into your building. Some of the droplets are large and are going to fall to the ground quickly within 1 to 2 meters, and some of these droplets are smaller aerosols that are going to not drop rapidly. So let's take a closer look at those droplets. When they come out of our airways, they're about 100 microns in diameter. They're in 100% saturated air, because that's the saturation that you need for gas exchange in your lungs. And if the indoor humidity is somewhere over 40%, those 100 micron droplets will shrink to about 50 microns. And all of the salts in the droplets will also condense and increase in concentration. And at that size and that salt concentration, many pathogenic viruses and bacteria are actually inactivated. Their structure is rendered incompatible with ongoing infection or metabolism, which is kind of the definition of life if you're a bacteria. In some environments, those droplets shrink down even further and the salts concentrate even further. And what we're finding is that at that salt concentration, and maybe for other reasons that we don't know about yet, many organisms become preserved, and they're not dead, they're just dormant. And we used to think that those little teeny tiny droplets or particles were not infectious because we couldn't grow them in tissue culture. But using these metagenomic analysis tools, we are now learning about this state of dormancy where those droplets they're just taking a snooze. As soon as they're inhaled by someone else or enter another person's body one way or another, they can become reactivated and reinfectious. So again, back to that lady walking into your house, there's really 3 places where we can protect ourselves. One, we can prevent the viral load from entering our space. That's kind of a behavioral intervention, or you can lock your door, but hopefully they can wear a mask, they can stay far enough away from you. But it's really this middle column that we're focusing on for engineering solutions to disease transmission. In the right-hand column, the vulnerability of the secondary person is something we usually leave to physicians. We look for vaccination, we look for good disease treatments, we try to get enough sleep and eat well. So again, the first column is really a behavioral intervention. So let's take a look at this category, this column. And like Walt said, I was one of the authors, as was Tracy, of the position document. We now know that aerosol transmission of SARS-CoV-2 has enough data to support that transmission route that we need to address it. It's not prudent to pretend that it's only contact or short-range aerosol transmission that we need to worry about. Okay, so back to the question of how do we know what we're doing that's good, bad, or indifferent in terms of indoor air management and human health. So I found out about a group of microbiologists in the Chicago area who were investigating how microbes move into and populate a brand new hospital building. So they are using these metagenomic analysis techniques in 10 patient rooms, 5 on one floor, 5 on another. The patients were controlled for acuity, 5 were hemonc, so they had some immunosuppression, 5 rooms were med surg, so they were just your average person coming into the hospital. So they set up monitors in the end spaces in the patient rooms for all of these variables. And this was in 2014. So if you've already seen this study, just bear with me. So they looked at all of these variables: temperature, hand hygiene protocols, pressurization, lighting, CO2, humidity, room traffic, room air changes, outdoor air. So they had about 8 million data points from monitoring these things every 5 to 30 minutes. And I said, hey, I'd like to look at patient outcomes, specifically infections, in those rooms with this huge data set to see if any of these are significantly related to infection rates. So just think about those for a sec. This is when I really became friends with Tracy, when she looked at this study, and her reaction was just priceless. So we sent all this off to our statistician, who came back saying the most powerful and statistically significant correlation was low relative humidity in the patient rooms, not absolute humidity, relative humidity, was associated with more higher infections, more, comma, higher infections. So on the columns, you have infections in the patient rooms. The blue lines, the average relative humidity. It only goes from like 32 up to about 42%. So I saw these data points. I thought, that's ridiculous. That's seasonal. You know, they've missed something. So we fired our statistician. We hired a new group who came back and said, you know, you physicians are so hard-headed. If it's not what you expect, you don't believe it. But this is an independent variable, significant to p less than 0.02. That lower relative humidity is associated with a higher infection rate. I was still skeptical. So we did another study. This was after 4 years in a nursing home, where we looked at all the indoor and outdoor parameters and correlated them with data on elderly patient infections. And once again, with relative humidity on the x-axis and infections on the y-axis, you can see, especially with GI and respiratory, bacterial, and viral infections, dry air indoors was associated with higher infection rates. And there's this 40 to 60% sweet spot where the infection rate was at its all-time lowest. So I thought, okay, well, this is interesting. Still just a correlation. So this study came out in 2018, I believe. Yeah, 2000, says it right there. This was done by the Mayo Clinic in a preschool. So they looked at, they humidified a school in the winter between January and March to 45% in half the building. And in the other half, same types of students, they let it do what happens in a building in the winter in northern Minnesota, bring in outdoor air, heat it up, relative humidity falls. So they looked at the number of particles in the air using metagenomic techniques that were carrying the Influenza A virus. They subsequently looked at how infectious or how active those Influenza A viruses were, and then ultimately the number of children who were absent from Influenza A. And you can see there was a dramatic difference with many fewer kids absent in the humidified part of the school. So putting this together, we now know there are a couple different steps where relative humidity less than 40% is associated with steps that cause increased infections. There's greater transmission through the air. There's evasion from surface cleaning, from resuspension and resettling. And for reasons we don't fully understand, in low relative humidity, many pathogens are more active or more infectious. So I'm going to move along here because I think I'm at the end of my time.
Well, I'll give you 5 more minutes, Steph.
Does that mean you're interested?
Yes.
I'm kidding. I mean, I'm glad. Well, okay, so droplets come out of my airways, 100 microns in diameter. They rapidly shrink to become what are known as droplet nuclei. We now know that many of those are still infectious, even though they may be dormant, and they float through the air and go far and wide and can infect people that have had no direct contact with the initial sick person. And this is showing that in guinea pigs with influenza A, when the relative humidity is low on the x-axis, the infectivity is high. And at 40% RH, something happens and the infectivity plummets. With many organisms, that goes back up again at 60%, but we consistently see across different kinds of viruses, bacteria, whether it's envelope, non-envelope, gram-positive, gram-negative, that there's a sweet spot, 40 to 60%, not more than that necessarily, in comfortable room temperatures where you have the least infectious activity of the organism. So that was, sorry, collect my thoughts. That was influenza. This is the coronavirus. So this is showing that this is a logarithmic scale, but the black line at the top shows the decrease in activity over time at 20% RH. The green line, again, logarithmic, so it's still a significant decrease, is at 80% RH. And the blue line is showing the most rapid inactivation at 50% RH. And the references are in the back of this presentation. So you can, geez, sorry. It's telling me to stop. Sorry. How do you turn that damn thing off, Tracy? So if you put all these different routes of transmission against relative humidity, and we're seeing this trough of infectivity, the least infectivity starting around 40%, extending more or less to 60%. So our very last part, what about this third column? Is that something as building professionals that we should even be thinking about? It ends up how you manage the indoor environment does affect your immunity. So this was a study done at Yale where they said, why is it that we get the flu in the winter? So they put in all the variables, vitamin D, crowding, melatonin, temperature, and came out with relative humidity indoors being a key factor. So they said, well, why? Why is it that if you get the flu in the wintertime with low RH, you're going to be the person all the way to the right, potentially really sick? So they said, why? In this study, they used genetically engineered mice because you can't really take out the lungs of your colleagues or subjects and chop them up and look at them. And you can't do that again and again with people. So they did it with genetically engineered mice that had the same immunity as people. So they think about when you're exposed to a virus, you inhale it. Then you have this first line of defense called the mucociliary barrier. So there's mucus, sticky mucus in your respiratory tract that gloms onto particles, whether they're inorganic or microbial. You have these little hairs called cilia that are constantly washing upwards. And if a particle happens to get by that step, there are these other cells in our immune system that come along and eat up any particles and try to prevent infection further in our respiratory tract. They secrete interferon, which is protective, and if necessary, the other branch of our immune system is dragged into the scene to help protect us. It ends up in Dr. Iwasaki's lab at Yale found that when the ambient relative humidity was at 20%, all of these steps of protection were impaired. Not only was the mucus more viscous and the cilia couldn't work, which you can kind of intuitively expect, but these other steps were impaired. The interferon wasn't produced. The other cells were not mobilized to reduce or repair any tissue inflammation. The second arm of our immune system wasn't activated as effectively as at 50% RH. So this really is important because it's a strategy indoors that not only takes care of the middle column, decreasing the burden, the bioburden in our breathing zone, decreasing the activity of many microbes, they don't all respond the same, but many do, including COVID-19. But proper humidification also supports our immune system. So if you look at the CDC website a couple of years ago, before ASHRAE started thinking about infectious aerosols, the list of airborne organisms, disease transmission pathogens was fairly small. But now that list is much longer because we're learning that most infections that are spread through the contact route can be spread through infectious aerosols. So this is a dramatic shift. So if you think about it, why do we have buildings? We want to keep the rain off of us. We want to, not get washed away by a flood. We want them to be energy efficient, but we really have buildings to protect us as occupants. So it's so exciting for me that ASHRAE and the Center for Health Design, are really leaders in bringing in this third strand of building management. So if I go back to this environment, I think, okay, the relative humidity was great. We weren't selecting for pathogens, and the people probably had a very robust immune system. So I believe that with proper indoor environment management and proper indoor air management and seeing the building through the lens of health, we can turn around this trend. And by using health as a lens to probe building management without preconceptions, we found that for one thing, relative humidity in this mid-range zone is really important. It's important to decrease pathogen bioburden. It's important to support our immune system. So I think that it's really exciting that we're bringing the evidence-based medicine lens to buildings. So I say thank you, and I think I went a little over, and I apologize.
That's okay, Dr. Taylor.
Give me
Thank
my
you. Great. All right, Tracy, you want to go
Trace,
next?
sorry.
Okay. My video started back up. Thank you. All right. Well, I love the information that Stephanie has to share, and she and I have talked about that relative humidity piece a lot. So what I'm going to do is, see if I can get this up, is give you all a little bit of history, and not too much history, but kind of information about the recent information on COVID-19 and how that's affecting what we have to do with our building HVAC designs. So I'm currently serving on ASHRAE TC 9.6 for the Healthcare Facilities Technical Committee and on the Epidemic Task Force. So we've been busy since, oh gosh, even January, we were talking about the Wuhan virus in our infectious diseases subcommittee meetings. We were talking about spillover from infectious diseases from animals, which is what SARS-CoV-2 is. Same thing with MERS. I think maybe the host is camels over in the Middle East. But we look at diseases coming over from bats. Bats make up about a quarter of all the mammal species. They tend to congregate really close together. You can get like 600 bats in a square foot. And so they have a lot of viral transmission going on amongst them. But this was a slide from February 5th, 2020. This was just after our infectious diseases subcommittee met in Orlando, and we were talking about the coronavirus, and Johns Hopkins got this web page up where you could track cases, and you notice the total case number is just over 24,000, which was huge to us at the time. And the map was only zoomed in on China because there really wasn't much happening elsewhere in the world. And then now we're over 12 million cases as of last night worldwide. So big impact from that. I want to share a little bit about what it is that we're learning. We know the size of the SARS-CoV-2 is about 0.12 micrometers. It's pretty small, but like when you visualize the cough that Stephanie was showing in her video, those virus particulates are attached to other droplets, and so they're much larger, which means we can catch them in filters unless they get dried out and become really small. We have learned some things from super spreader events. There was the Skagit Valley Choir, which is in my home state of Washington, where a whole bunch of people came together in March and they were singing, but they had socially distanced, they were washing their hands, and still a whole bunch of people became infected. And since then, they've been quantifying how much infectious virus they think the initial case person put out. But there have been cases like that. The restaurant, which Jim talked about last time when you guys all got together, and then other super spreader type events where people are coming close together. So we're learning a lot of information about this virus and the transmission of it from those kind of events. There was also a paper that was put out recently from the University of Nebraska Medical Center, where they were looking at viral shedding and looking at where they were finding RNA pieces of the virus, and this lists a few of those locations. Something important to remember, though, is that we haven't found viable virus yet of SARS-CoV-2 inside air handling systems or coming out of those supply diffusers into patient rooms. It may be there. It's difficult to catch virus in that kind of situation and prove that it's viable. We have PCR analysis now, so we can figure out that it's there. And but trying to keep it in a state where it's not going to die before you can verify that it's viable or not is challenging. And there's not a lot of really great protocols in the industry for how to do that and get it to work right. And every virus is different. So there are some studies that I'm aware of, one that's about to go to preprint on this topic, but so stay tuned. We talk a lot in our infectious diseases subcommittee meetings about toilet plume. And toilet plume is the real deal, and we can do research and study. In this particular case that Dr. Johnson had published in the American Journal of Infection Control, they seeded it with C. diff and flushed it again and again, and they were getting particulates in the air and on nearby surfaces after 24 flushes. I don't know if you're aware of this, but there's even been studies to look at the spread of infectious diseases throughout the world by monitoring the content of waste and airplane sewage. So there's a lot of viral and bacterial contamination in fecal matter, and you can sample and test for that. So important if you have facilities that have lids with toilets or toilets with lids to keep those lids down. I'd much rather touch toilet seat lid and put it down and then go wash my hands than not have a lid at all. And then you can't wash your hands, but you've basically got contamination all over the place. This is a study that was published in April. This is a preliminary piece that the Department of Homeland Security biodefense folks worked on, where they looked specifically at SARS-CoV. They looked at surfaces and they also looked at aerosols. And this is a graph just showing aerosols. It shows how quickly you get decay when you have full sun and higher relative humidity than if you have a no sun, no UV light, and low relative humidity. So they were playing around with this, and we saw this paper back in April, and then just recently they did some more work. One of my colleagues, Luke Loom, who also is on the Epidemic Task Force and on the Environmental Health Committee with Stephanie, ran this graph from their data showing the relative humidity and the half-life, which this is not a linear relationship exactly, but recently the Department of Homeland Security came out with this new calculator. So I put the website up here so you can go and play with it yourself. It's pretty neat. Important though, there's a little small section of about 5 bullet points with the background information of where this came from and some caveats. And it's always important when you're playing around with these simplified calculators to look at those caveats. This shows that same data that they had, but you can go in here and you can adjust the amount of UV light, you can adjust the temperature, you can adjust the relative humidity, and then you can look at how fast that virus is going to decay in that environmental condition. It looks to me like they simplified it a little bit and made some of the data a little more linear than it really is. But so for example, here's a 75-degree dry air half-life, 50% half-life in 21 minutes. Raise that relative humidity up to 40%, and it drops down to 15 minutes. And keep in mind, this is relative stuff. This isn't like exactly set 15.63 minutes, but it gives you an idea of what kind of impact the environmental parameters can have on the survival of virus. And that's a really important thing for us to understand. I think that I always say your ability to guard against failure is only as good as your ability to imagine the worst. So, you know, people don't want to be thinking negatively all the time, but in engineering, if you're trying to have a system that works right, you have to think about all the ways that it could fail. And if you think about how something could go wrong, we can say, well, how do we prevent that from happening? What do we do as a safeguard? What do we check? What do we calculate to make sure things go right? So we have to have that mindset when we're doing design of saying, well, what could go wrong, and not being afraid to explore those ideas. Somebody thought, what would happen if the virus got drawn into an air handling unit, you know? So somebody went and looked at that. And this is a copy of a preprint, or slides from a preprint that we just received. this author down here, Kevin Vanden Wijmelenberg, is a colleague. He came with Stephanie and I to a healthcare symposium at Harvard a couple years ago. It was when I first met him. But they looked at the presence of SARS-CoV-2 RNA in a healthcare facility in air handling units. And they took samples above, in front of the pre-filters. They took some samples in front of the final filters, and then they took some samples on the damper with the supply air. And they did a detailed PCR analysis to look and see, was there virus inside the unit? And no surprise, there was. There was a pretty good amount in front of the pre-filters, as we would expect, less in front of the final filters, and maybe a little surprising, but not really, that there was a fair bit at the supply air dampers. The test that they use to look for the presence of RNA is very, very sensitive. There are small viral particles that are going to dry out more as they go through an air handling unit, so they get smaller, and so they may be traveling through. There could be leaks in the filters. There's certainly points of lower efficiency in any filter, but the final filters in this unit were MERV 15 filters, so they're a pretty good set of filters on the unit. But this was the first preprint study that I'd seen published that showed, okay, there definitely is viral material inside the air handler. And next step is to try and figure out, is there anything that's viable that's going through there? But early on with our epidemic task force, ASHRAE and our healthcare group said we wanted to provide recommendation guidance if you were changing filters in an air handling unit to wear some protective gear. And we said, we don't know if there's viable virus inside an air handler, but we think it's possible that that could be the case. And so it would be prudent at this point, because of the risks involved, that you wear PPE, and some people take like a hairspray or a spray paint or something as a fixative and just spray the front of the filters before they change them to just fixate anything that's on there, and then you can bag up those filters and throw them away. There's also some good research done by another friend of mine, Damon Greeley, looking at how microbes move in the operating room. And I know Jim showed some studies that Kishore did earlier, looking at operating room airflow. And in this case, they're looking at the environmental factors that affected how microbes moved. And they figured out that when you increase the relative humidity in the operating room, that almost acts like a blanket of moisture that diminishes the ability of microbes to move around as much in the space. And so they found a benefit here when they looked at colony forming units of fewer colony forming units when the relative humidity in the OR was increased up to around 35 to 50% relative humidity. Didn't find a statistical difference between those two values, but definitely saw a higher colony forming unit count in the low 20% RH. And that's something we've been debating, because ASHRAE Standard 170 moved the relative humidity limit in the OR down to 20% RH. And there are good reasons at the time for why they thought about doing that, but there's new information, much of which Stephanie shared, that makes us reconsider that. So NASA Nicholas Taleb said this, and it's a fun quote that I like to keep in mind, and that is that the trick in life and risk management, which Walt talked about, is to have as much respect for the experience that you get before you get it as we would have after you get that experience. And sometimes people don't learn lessons unless they have to go through the school of hard knocks, but it's really beneficial for us and the people that are counting on us to take care of them and protect them if we learn lessons from other people. So it's really important, like these activities like Grainger CAN, where we can share information and lessons learned and be really open about it. And we need hospitals to be more open with their data on infections so that we can learn from that information as well. Thought I'd talk a little bit, since we're talking about HVAC systems, about anterooms. Right now, ASHRAE Standard 170 doesn't require an anteroom on an airborne infection isolation room. I've looked at some papers. There's been some mathematical modeling to try and show how much air escapes from a patient room out into the corridor if you don't have an anteroom versus if you do have an anteroom. And more of that research has come to light, and it's important. And if you really have somebody infectious, the anteroom is the way to go. I like to ask people, if you had somebody in a patient room and they had tuberculosis, and I guess now I'd change that to if they had SARS-CoV-2, would you sit down in a chair outside their room in the hallway without an anteroom and sit and read a book? Aside from the fact that that's probably a life safety violation to have a chair out there like that in the corridor, but most people would say no, they would want to have an anteroom or not be that close to somebody that's got that kind of an infectious disease. So I think we need to look at changing our requirements and saying we need to have those anterooms there, that they're really important. But we have to understand what some of those barriers are. Why don't we have them? Well, there's added cost. It affects the floor plan. It can make patients feel more isolated and away from their caregivers. It's harder to watch patients if you're a healthcare provider. So there are different things that make us not want to do that. And if we decide, well, it's really important to have them, then we have to work around that and say, what can we do to the way that we design these facilities to make it more cost effective and more practical from a patient care standpoint to include an anteroom. But I think some people just kind of get afraid of being paranoid. I know at work, my staff, they showed me a photo of me at Halloween in 2014, and I had dressed up like an Ebola fighter, and I had my office all outfitted with PPE and note on it saying, you know, please gown up before entering. And I've always been kind of a prepared sort of person, but I like to think of it more as being ready and not betraying the trust of people. You know, the public expects that when they go to a hospital that things are going to be right, that they're going to be taken care of, that the environment is suitable. They don't think about whether or not the ER they just walked into has 100% exhaust out of it. But, you know, if they go to an urgent care clinic, they might not get the same environment as when they walk into a hospital. But the public doesn't know that, but they're trusting that we're doing the right thing. And I think we need to be careful. We don't want to be crazy paranoid, but we need to be mindful of the expectations of the public and what they think we're going to do to help take care of them. We can't always predict the way things are going to go. I mean, the whole Fukushima disaster happened partly because they built up a big protective wall at that facility and said, this is the biggest tsunami surge that could possibly happen. And what they forgot was that when they had an earthquake and the plates shifted, that the whole seabed floor changed by about a foot. And that meant that their protective wall was about a foot short of what it needed to be to keep the reactor safe. And they ended up having a huge nuclear disaster, and who would have known? But sometimes we look at events and we say, oh, this is the worst thing I've ever seen in all my years, and we'll see flooding, and people say, I've never seen it flood this bad, and they've lived there for 8 years or 20 years. We don't always look at a big enough horizon and think about how often are we breaking records of racing, sprinting, athletics, breaking records for temperature. We see records fall all the time. There's always something bigger than what was there before. So it's kind of funny that it surprises us so much. But we need to do some more research to understand things better. Here are some key things we're trying to figure out about SARS-CoV-2. One of them is, how much airborne transmission is there really going on outside of the things we know, like intubating a patient that's obviously a high risk, and we make recommendations to guard against that. We're looking at whether or not there's viable virus inside of HVAC systems that could be transmitted into another room. What is the effective dose? That's going to vary a little bit based on the health of the person. And certainly if you are healthy and your immune system is functioning well, you are more resilient and less likely to become infected, but we don't really know yet what that effective dose is. And particle sizes, we're trying to figure out what size particulate are people putting out, and do we have a lot of that submicron thing going on where particles are traveling for long distances and spaces and infecting people that are more than that magical 6 foot away. And then environmental conditions. We looked at that calculator. There's a lot of good information about what kind of environmental conditions are beneficial or not, but there's also conflicting information. And some studies are showing that certain temperatures or humidities are better than others. and it's different from what other people have found. And so we need to continue investigating that and understand that better, because when we decide, what are we going to do about this? We have transmission and here's how it's happening. What steps can you take? We can't necessarily do all the steps we want to take in every situation. There are realities of budget and money in some cases, and we want to be able to prioritize what we do, and the more research we can get and the more information we have, the better we can inform our priorities. So this is just a little comic that I think is kind of cute, where somebody's trying to get their device charged up and they end up unplugging themselves. And sometimes our priorities get mixed up and we need a reminder to get them back on track. This is just a quick blurb, something I found was interesting. You know, there's still a lot of research going on by the clinicians on how SARS-CoV-2 affects our bodies. And I think it's important for us to just keep tabs on the kind of research they're doing, because some of those things that they learn that help them with different treatments and clinical approaches could also end up having environmental impacts. And I think we should continue to watch that. And we've got new tools. This is a neat thing that I saw where they've got these virus sniffing dogs that can sniff out avian influenza. This is at a project site that I was at recently, and I'm sure they're going to train dogs to be sniffing out SARS-CoV-2 impacts on people too, but it's pretty amazing what they can do there. Another new tool to just highlight is a thing called pedestrian simulation modeling. So we have a lot of fire protection engineers in our company, and they use software to model how fast people can get out of a building in a fire. And they went and repurposed it and said, can we use this software to figure out how to keep people socially distanced in a building? How do you feed people in through a building? Should you stagger shifts for folks like in an office building? What if you're trying to do screening of patients and people coming in and you don't want to put a whole bunch of people in a waiting room? How many people can you do in a certain amount of time? What's the throughput? We did a neat study. They did a case study actually in an art gallery, and they looked at how people moved through the gallery, and they adjusted the positions of the pathway where someone would go through it so that they could give people time to do what they needed. Either you're checking in with a receptionist at the front of the ED, or maybe you get over here and you need to get triage, you get your blood pressure taken, but how fast are people moving through a space? And if you want to keep them separated, can you rearrange the flow of things and improve that separation? And in the areas where you can't, then you know, maybe that's where I do something else really specific to help with the environment if you can't keep people socially distanced. So we have tools like that that we're making use of. And then the ASHRA Epidemic Task Force that I'm on has a whole bunch of information on the webpage. We brought that up the last time, and hopefully you guys have been able to go and see that webpage. You can send an inquiry, submit a question, and someone will get back to you really quickly with an answer on issues you have or something you want to know about. There's a whole set of slides with guidance specific to healthcare facilities, and there's a main cover page with links to different topics that you can access for information. And we've had a lot of people collaborate on that, and that gets updated as we find new information and learn new things. We're improving that guidance because this pandemic is continuing to go on, and we find out new stuff, new research, or just new best practices that we want to pass along. So I encourage you, if you've been to the site before, to go back and look for updates on that. Last week, how can we modify the built environment to mitigate risk? And I might have to pause my little internet connection here. I can keep talking, but I have when my house phone rings, sometimes my internet gets kicked off and I just heard it ringing. So, but airflow patterns, we can look at things, and I could go over this maybe in another presentation. This is just sort of meant to be a teaser page of things that I have looked at, environmental conditions, and yeah, I'm just going to go log back on here in a minute, but I'll just keep sharing some information verbally with you while I reconnect. Looking at airflow patterns in spaces, looking at increased ventilation versus dilution. We've done some some calculations and put some graphs together to help people evaluate if it's better to increase the filtration level at their facility or if it's better to try and do dilution by increasing the amount of outside air that they have. And we know that in some environments, some HVAC systems can't handle more outside air, or it's just a greater energy penalty. And so that's a factor, but we know that filtration is very effective, and you can do some trade-offs and look at some graphs and see for your space what might be the better option to do. I want to talk just real briefly about the humidifier piece that Stephanie brought up. So let me get my video back up here again. Just a second. And see if I can share my screen again. All right. If that comes up. Can you guys see my screen yet?
No, it's dark, Trace.
Okay. Well, I'll give it a try here again in a second. I just have one more slide left.
I'll share it on my end, okay? I just
Okay, that'd be great.
get to your screen.
Thanks. Yeah, it's the second, well, I guess the third to last slide that says great indoor air RH debate.
Okay.
I mean, basically, we understand that buildings don't really care about what the humidity level is. We think about historically that the drier the air we have, the better that it is. And that's not necessarily true. Yeah, thank you. Go up one from that, the slide before that. Perfect, thanks.
Oh, sorry. There.
Oh, up one, the one that says the great indoor. Perfect. No. Right in between the two that you're doing.
There we go.
There. Yeah. Thank you very much. Appreciate it.
No worries.
Yeah. So, you know, we've thought so much. We have ductboard in our hospitals, and we have situations where we just worry a lot about mold in a building, and so we want to dry that building out and protect it. But now we've learned that humidification has a lot of great benefits for us, and so when Walt was talking about how they started to think of the building as an infection control device, I think about a humidifier as an infection control device. And when you think about it that way and say, gosh, this might really matter and make a difference in our infection rate and in our health, then the fact that the humidifiers are really a pain in the butt to maintain, you know, you've got to clean them out, you've got to make sure you don't have scaling, you have to really be attentive to the way they were installed, to the way the controls are functioning, and make sure that those were set up right and that they are not going to fail in a dangerous manner if the power goes out or something happens like that. It's worth it. It's kind of like an emergency generator to me, where, gosh, you got to test those things all the time. There's a bunch of paperwork around them, and they're not the cheapest things, but everybody knows we want to have that generator work because it's super important when the power goes out. Same thing with having good humidification. If it's helping to keep us healthy and lowering the risk of infection, then it becomes critical and it gets more attention. And so I think we need to keep that in mind. If you could go to the next slide, please. Thanks, Jill. So I like this shirt. The Asteroids Are Nature's Way of asking how is that space program going along. We sometimes figure out how to solve our problem by just denying that it exists. And COVID-2, or SARS-CoV-2, COVID-19 has really made us pull heads out of the sand and say, this is here and you can't ignore it. We have to deal with it. So we're working really hard to come up with better ways to modify HVAC systems to handle surge conditions. We've got ventilated headboards that we've done some research on with CDC and NIOSH to say, okay, here's how you could hook something up that might do a better job of containment in a facility. And we need to keep sharing those kind of ideas, especially the real cost-effective ones that have some research backing to them. So we know, hey, this is effective and it's worth it. Then we know where to put our money at and our time. So I hope that you'll continue to share ideas. If you could go to the next slide. Just feel free to contact me if you have ideas, things that you want to brainstorm on, or you're looking for input about guidance that we have, and maybe you have another idea that you want to share with the rest of the community. The Epidemic Task Force would really like to hear ideas and also hear about what kind of challenges you have to the things you've been trying to implement. I know, like in our long-term care facilities, people wanted to make adjustments during the pandemic, and their HVAC systems just weren't very flexible. They couldn't do what they wanted to do, and so we helped them prioritize, well, if you could only do this or only do that, which would be better and why, and give our best professional judgment that we can based on our knowledge. And then in areas where we say, really, we just need to do some more research to know the right answer, we can help fund that research through the ASHRAE committees and find out those kind of answers. So don't hesitate to reach out and contact me, but hopefully we'll have some good Q&A time in the next bit. So thanks, Jill, for covering me on those last couple of slides.
Great. Well, thank you, Walt, Stephanie, and Tracy. All three very, very informative presentations. So now's the time to really open up the floor to everybody else for questions. As I said, Jim Crabb has joined us again from last week, and so I'm going to just open it up to people. If you wouldn't mind introducing yourself when you ask a question, so people know who you are and where you're from, that'd be great. I know there have to be questions out there.
I'll start. So this is Lynn Kenny from the Center for Health Design, and I was fortunate enough to attend the symposium where Tracy and Dr. Taylor presented a couple of years ago at Harvard University. And I still have my little relative humidity monitor on my desk here, because, you know, it really like sticks in your mind. All right, yay, here's mine. So this is a question I've had for a long time. If relative humidity has that kind of power in the built environment, does it stand to reason that it also has that kind of power in our natural environment? Like, is it not healthy to live in a dry environment versus a humid one?
Can I take a stab at that one, Lynn?
Please.
So, you know, if you think about it, well, I get my hygrometer up and running, but if you think about it, when you were outdoors, which is where we get meteorological reports from, the conditions are very different from indoors. So, for example, I grew up in Tucson, Arizona. Or at least I got older in Tucson, Arizona. Not sure I ever grew up. But anyway, so when you're outdoors, it's 90 degrees or 85 degrees and 15% relative humidity. As soon as you go into a 70-degree air-conditioned building, the relative humidity changes dramatically. And so it's really important to differentiate between indoor and outdoor climatic factors. And for example, I happen to be in Virginia right now, at my brother's beautiful farm. And outdoors, it's like 90 degrees, and I don't know what the humidity is. Indoors, it's air conditioned, and I have my other hygrometer that's turned on. When I went to bed last night, it was 35% RH in the air conditioned bedroom. So it's, and I have a colleague in Florida who goes around with his hygrometer measuring indoor relative humidity in buildings. So you have to just really be careful when you think about meteorological conditions versus the indoor environment. And right now, MIT, the Department of Aerobiology, and I are doing a huge study using data points from government interventions to healthcare, for hospitalizations, looking at the different aspects that relate to COVID-19 deaths. And we're finding, and we've been meticulous in not skewing our analysis. So we're using unsupervised machine learning in our database analysis. And again, it's the indoor relative humidity. And granted, some of that's calculated by outdoor temperature and absolute humidity. But again, across the globe, it's turning out to be one of the most powerful forces that are variables that's associated with higher death rates. So be careful. Just make sure you know which environment you're thinking about, indoor, outdoor.
Thank you.
That was a long answer, sorry.
No, that's good. I mean, right, Stephanie, we take that outside air and then we condition it. And when we condition it for the building use, we change that. We do a lot of things to the air, you know, heating it, cooling it, and we definitely, especially in those northern climates when it's cold, you know, we bring that air in and then we're drying it out so much, relative humidity wise, but it's almost unnatural in a way what we do to the air to bring it into the building to make it work for us.
Yeah.
Keep us comfortable.
And we don't have skin sensors for dryness. So it seems like we design our buildings for what we sense, you know,
The
sight, smell, sound. Sorry, I'll be quiet now.
So what generated this whole discussion was that the engineers were wondering about, you know, what rooms needed to have negative pressure. Did they need to worry about the way the air flowed within an environment? And so I guess I'd be interested in hearing what people think, you know, about this whole issue of air and how much negative air needs to be done and what's the best way to do that. We saw some of that from Jim's presentation last week, but I'm just wondering, you know, what people's thoughts are that. And certainly for the engineers, ask your questions because, you know, Richie, I know, for example, you were worried about in the ambulatory setting, you know, do I need to have negative pressure air rooms there, or should I worry about aerosols after a procedure, those kinds of things. So I'd be interested in hearing, you know, questions or comments about that.
That's definitely not my area of expertise.
In light of not as, you know, if someone wants to chime in with a specific question, but I'll provide a little bit of insight about our recommendations. And I thought might help. I'm going to try and share my screen real quick again. This is the ASHRAE COVID-19 webpage that we created. And there's a section under here on the main page, information, there's the position document. But if you go over here to buildings and look at healthcare, which is this top one right here, there's a PDF that you can download, or you can access it directly from the web page. But I like accessing the PDF because I think it's a little bit more user-friendly. But it has links to all kinds of information for specific spaces about what we recommend in terms of guidance. And so when you start thinking about post-COVID pandemic time, that's going to be a big challenge where we're thinking, what do we need to do differently than what we did before, or do we? And you know, spaces that we kept neutral before, should we keep them negative or positive? I think we have to look at each facility case by case and decide what makes the most sense with what's available. But there's a lot of asymptomatic spread, so people could continue to bring in this or other infectious diseases over time. And you know, the question is a lot of how far do we want to go with that, because there are operational and energy and first cost issues with that. But this is the task force healthcare update. You can see it was updated last in June 17th, 2020. But we can go to different spaces and say, you know, one thing I thought might be helpful to just look at is the source control options for patient beds, for example. you can go in here and look at like this ventilated headboard that CDC NIOSH had put together and ideas for rooms. You know, this kind of a thing works really well during the pandemic. It's very effective at containment, and there's good research to back that up. But long term, that's not really practical to have that kind of setup in patient rooms. So there's no requirement for pressurization in a regular patient room, but I think we look at how many airborne infection isolation rooms we have in hospitals and say it's probably not enough. Given what we've learned with this pandemic, we weren't prepared enough with spaces that could help us, or areas that could be rapidly converted into that without having it, you know, have flux duct all over the place, or risk of life safety code compromises in doing that. So I know that Doug Erickson talked last time about some of what FGI is looking at doing. There are groups, I know ASHRAE standard 62.2 is getting ready to meet. I think they're meeting next week, and they're going to be talking about whether or not a air handling system should be required to be compatible with MERV 13 filters. Even if the code doesn't require MERV 13 filters for the use, they may change that standard to say, well, you should put in filter housing where you could install a MERV 13, and the fan should have enough static to handle that if there were a pandemic type situation. I know they did a lot of research already on filters and said, okay, what do we have for MERV 8 filters, and how thick are they, and MERV 13, and what's the pressure drop? And they found more variation in pressure drop between different kinds of MERV 8 filters or different kinds of MERV 13 filters. Then they found pressure drop difference between some MERV 8 and some MERV 13. So it seemed pretty reasonable to say, if you got a good quality MERV 13 filter, you could find one with a pressure drop that's low enough to fit in an air handler that normally handled just a MERV 8. And we think about this for pandemics. Where I live and in many other parts of the United States and the world, we've seen more awareness of wildfires. There's more knowledge and understanding now about how wildfires impact our cardiovascular health, and so people want to be better protected for those. And we've had a lot of clients in the last couple of years ask us what they can do for their facilities to protect their buildings when there's a lot of wildfire smoke in the area. And having interchangeable filters is one of those strategies. So, you know, if we can find ways to make a big impact and improve our indoor air quality by having systems where we have flexibility with filter changes, for example, then we want to take advantage of that. One pharmaceutical facility I'm designing right now can switch the MERV 8s out for the MERV 13s on the pre-filter side, and then they have a MERV 14 final filter in the air handler, and they can swap that out for a 99.97% HEPA in the final filter, and do that during wildfire season, and it keeps their particulate counts down enough in the space. They have real high efficiency HEPA filters at the rooms, also in the pharmaceutical rooms, but there's other spaces served off the air handlers that don't have room HEPAs. And so being able to put those up at the main air handler can really reduce the particulate count in the space. We've had a few other labs and even an office building where they've asked to have that kind of filtration option in the future for wildfires, and now they're really glad that they put that in because they're running it that way during the pandemic. So they're thankful for what they did there.
Quiet group today. Richie, I know you have to have some kind of question.
Yeah, I'm still pondering that graph that I saw with the 40-60% humidity. That was pretty impressive. Just to understand what that does. I do have a question about what the thoughts are about code changes. ASHRAE 170 table as an example. Is there any thought that, like, OR pressures could possibly change. Is there any thoughts about allowing negative pressure or isolation rooms, allow them to, let's say if it's designed to be a negative pressure room, switch it to allow it to go positive for a given period, so it's not negative all the time like we used to have it. So what are your thoughts about that, Tracy?
Sure. So on the operating rooms, the advice so far has still been keep those rooms positively pressurized. You know, when you bring an infectious person into the OR, there are things you can do to mitigate the risk to the healthcare staff. You can intubate them in an airborne infection isolation room and then transfer them to the OR after they've been intubated. And then all the PPE that the healthcare facility staff wears, you know, they could go with N95 masks and shields because their proximity to the patient is really close. There? Yeah.
So just thinking about the conversation from Dr. Taylor about that training ground in Africa that she went to, that clearly wasn't positively pressurized space with very little PPE and very low infection rates. So I just wonder, you know, the accuracy, if in fact relative humidity plays such a huge role as the data's talking to me about, then pressurization plays less of a role than relative humidity.
So I'll jump in here. For your first talking about switching positive pressure rooms, you know, switching negatively and positively pressured rooms makes me very nervous because the kind of patient that goes in each is exactly the opposite. That, you know, so negatively pressured room, somebody highly infected, infectious, positive pressure, somebody with very little immunity. So
well, I'm not even saying full positive pressure. I'm saying like slightly positive, a neutral to slightly positive pressure. I'm not saying I definitely wouldn't put an immunocompromised person in a room that somebody just had Ebola or COVID, and certainly not, right? That's not,
yeah,
not the objective there.
But in terms of the humidity piece, you know, I was completely blown away by the results of our first study that highlighted the importance of it. And I think from a holistic point of view, it has an impact on the air and has an impact on our immune system. And one thing that I didn't get into because, you know, it's another 15 minutes of talking, but also in the time of COVID-19, we don't really want to think about all the good microbes. It's like right now we're thinking about microbes being bad. But it ends up that the organisms that tend to survive in an anhydrous environment, whether it's air or surfaces, are the ones that are associated with the highest pathogenicity. So the bacteria and viruses that tend to do well in dry conditions are the pathogenic ones. And we've also found that antibiotic resistance can spread from bacteria to bacteria in the airborne environment not through the normal vertical route of mutation and formation of antibiotic resistance, but through horizontal gene transfer. That's like siblings having sex in the air, you know, without the sex. It's just inserting genetic material from one organism into another in the air. So I think that having an appropriate amount of water vapor is absolutely critical to supporting our health and to diminishing the pathogenicity of organisms. You know, it's not the only strategy, but I think it's one that we cannot neglect. So I think it's hugely important.
And let me give you some history where the OR conversation's coming from. So when you know, I work in a large facility. I didn't introduce myself. I'm Richie Stever, Director of Operations and Maintenance for the University of Maryland Medical Center. 2.1 million square feet, 42 operating rooms. We made 7 operating rooms have the capacity to go negative pressure, and we left one in negative pressure continuously. So that's our COVID OR. And so now I'm going to be totally frank with you guys. We're in our Joint Commission window, and Joint Commission's coming. And one of their standards says we're going to make sure that your pressure relationship is appropriate, and the pressure relationship for the OR is based on ASHRAE 170 table that says OR pressure needs to be positive, right? So I'm trying now to convince my physician colleagues and anesthesia colleagues that we need to convert this OR back to positively pressurized. And I gave them some different solutions on how to maintain safety, both for the patient and for the clinician staff. But they're really fighting me on it because they're really set on having a negative pressure room so that COVID, you know, those tiny microns aren't escaping into the common corridor where people are less protected. So I'm struggling with that and trying to convince them to switch back over. So that's where this high humidity, I'm calling 40 to 60% humidity high, is interesting and intriguing. So that's where I'm coming from.
So if I could jump in.
Oh, go ahead, Jim.
If I could jump in on that, because the question of an OR is one that I've been working with a client here just recently. I think the reality is we don't know that having a positively pressurized OR is actually helpful. I think we're doing that on the basis of kind of logic, common sense. You want to keep the nasty stuff out because you're cutting into somebody, exposing them to things. And, you know, I'm not sure what it's going to take what kind of analysis it's going to take to prove one way or the other, whether that's valid or not. But that is sort of been the accepted standard for a long time. If we accept that there is value in having a positive pressure in an OR, and we can, you know, I don't know if we accept that or not, but if we do.
You mean negative? Jim, you mean negative?
No, I mean positive.
Okay.
Because the positive is there to protect that patient who's been cut open, and you know, all the normal protections that patient has have been laid bare. So the idea is we want ORs positive. You're saying, well, here we've got this infectious patient, and therefore we want to protect the rest of the world from whatever this patient has. What we've done in a couple of cases now, more than a couple, is the best of both worlds. Is it essential? I don't know, but this is what we've done. We say, well, we want to keep the OR positive, and then we build an anteroom outside the OR to capture what comes out of the OR.
I agree with you, but there are space constraints, right?
There are.
And I'm also going to say we've done smoke tests where we've confirmed that the laminar flow around the patient with a laminar flow curtain and
Yes.
or a blanket, because we have both types, that the center section's filled in with HEPA filters, so that's more like a blanket, and then we have other ORs that come down like a curtain, right? Those are still positive in the patient care surgical arena, yet the space around that in the OR proper is actually negative to adjoining space. So we still think, but Joint Commission doesn't care. They're going to check the front
They don't care
door.
what you think, do they?
No, but they're going to check the front door, and the front door, their little tissue test is going to suck in, and they're going to say you fail, period.
Yeah, absolutely.
Right? And we don't want to hear any excuse. We don't want to hear about any test you did. That book, ASHRAE 170 table, that table tells me that OR needs to be positive, period.
Right. They don't care what you think.
No.
Yeah. And so this is what I'm describing is a way to manage that. And I won't tell you, I think it's essential that you do it that way, but it's a way to solve both things. We don't actually know that the room needs to be negative, to tell you the truth.
The anteroom?
Even the operating room, in order to protect what's escaping. Very small particles. Are they infectious? We don't know.
And very low volume too, right?
Very low concentration, at least.
Concentration, right. We also know you need to have a big slug to catch it, right?
We think. I'm not sure we know, but we think.
Yeah. You know, another thing to consider too when you're looking at a negative OR and you're doing your smoke test, which is really good to do because a lot of the basis on the positive ORs, we seen a lot of people that have done CFD models or done real life mock-ups of positive pressure ORs and looked at the airflow patterns in those spaces. And people are trying to understand better what's the optimum way to set up the diffusers and the velocities and things. But that is better understood than flipping that to negative and then saying, yeah, what does that do to the air distribution pattern in the space? So doing the smoke test is very helpful. One of the studies that Damon Greeley was doing in the ORs, they started looking at the Mayo stand, also that back table in the OR, and found that there was quite a bit of contamination on that. And that's outside of that core area right around the surgical table, and could be a source of contamination that's resulting in surgical site infections. And so would encourage you to take a look at what's happening to that, because that's where those sterile equipment is laid out on that table, opened up from its sterile packaging and exposed there, but it's not within that close window that gets the laminar airflow straight down from the diffuser. So that's something else to look at.
Yeah.
And then you were asking about the benefit of the OR and the relative humidity. A lot of facilities aren't sharing their data. I do know that Steve Friedman with Memorial Sloan Kettering Cancer Center, he's on ASHRAE Standard 170. He said that his infection control folks are insisting upon that minimum 40% RH, and that it has been beneficial for them. And so they continue to set up their ORs with those parameters. And I think, Stephanie, you've had some facilities that have gone, that you know of, that went down to 20% and reversed back. But I think, I don't know that you can say who, and there's not a lot of public data shared, but maybe you could comment on what you've heard firsthand.
Yeah, so it's Tracy. Yes, I have three colleagues in three different big facilities, and they're like, wait, we lowered our minimum allowable RH to 20%, and we've had a spike in our surgical site infections. And I don't feel comfortable saying where those facilities are. And that's one of the problems with hospitals. Hospitals are penalized for infections that patients get during their stay. And so it just makes recovery of those infection, the numbers is really hard. But what I just wanted to say, I don't know if anyone noticed on my front slide, there's a B for H logo. So our new platform, Building for Health, we're actually in real time monitoring indoor air parameters, microbial counts by colony forming units and PCR, and then correlating that with health outcomes of the occupants. Because I feel like it's really critical that we try to gather data so that we move beyond hypotheses and we get more of a glimpse into the real relationships between our indoor environment and human health. Things that, because they're huge, it's our lives and our families' lives at stake, and we don't want to be blocked by, financial penalties and, hypotheses and outdated data. So that's what my current business is correlating human health, indoor factors, especially air, and real-time microbial counts. And I'm super excited about it. So if anyone wants to know more, give me an email.
Well, I can help you with data. I mean, we've been running these ORs negative since February, and I'm sure I would have heard about negative surgical site infections from my infection control department by operating on those patients in those rooms. So
is that Richie talking?
Yeah, that's real. So there's real data there. That's not anecdotal. It's real.
Yeah.
Right. Doing real surgeries in a really negative OR.
That'd be awesome. I'd love to. And Mark Schwartz, there's another Mark on the call that I thought was Mark Schwartz. Mark Schwartz at University of Rochester Highland Hospital is just another one of these pioneering guys. And I know that I think Mark or work with him, but he is just a forward-thinking guy who's interested in this connection between the environment, microbes, humidity, surgical outcomes.
I thought I saw Mark on earlier. I don't know if he switched to a phone, but I thought I saw him come on at the beginning. So I don't know, Mark, if you're on or not.
Well, there's another Mark, and I was thinking it was Mark Schwartz. I was chatting with him. He's like, you got the wrong guy.
Yeah, that was Mark Dietz.
So if I could offer a little bit of a counterpoint to some of the ventilation issues that we're talking about, we talk about positive pressure, negative pressure, and we have a sense that it makes a difference. And that's really why we have those pressurizations in hospitals. We say a clean supply area needs to be positive to protect it from whatever's out there. And it makes sense. You know, we're talking about whether an OR should be positive or negative on the basis of what makes sense to us, not because we have the science to say one way or the other. We are doing some research right now in a hospital in California where we are measuring a number of different environmental indoor air quality variables, particulates and VOCs and some other things. We're not looking at health outcomes. We're just looking at what are the concentrations of these contaminants in the air. Because if we think that the contaminants are what cause adverse health outcomes, we're trying to protect this room from what's out there, then what's the difference between what's in this room and what's out there, what in terms of concentration levels? And we're finding there's no difference. So the focus of this study is there a difference? What are we doing the right kinds of things? And one of the recommendations likely to come out of this study is if there's no difference, why do we care what the pressure relationship is? And if you think, go back to what ASHRAE 170 did several cycles ago, you know, everybody assumed that if the room didn't, in the ASHRAE 170 table, if the room didn't say positive or negative, then it had to be neutral. And so there's an awful lot of gyration going on to make it neutral. And in California in particular, you can't have a variable air volume system unless you also control the return air. So there's a lot of money being spent to make rooms neutral. You can have VAV, but it has to, you're ramping up and down both sides. And so 170 some time back said, if it doesn't have to be positive or negative, then there's no requirement. So it can be positive or negative. It can change. It doesn't matter. There's no reason to think it matters. So, but of course that doesn't apply in California. They have their own code. And so that's part of what this study is about, is to say, is there value in that, or can we ditch that part of the code? But it is interesting to see how little variation there is based on the occupancy of a room or anything else. Now, we're not measuring specifically any virus. And I think we're not able to measure down to the really small particulate like a droplet nuclei. So it isn't the absolute definitive study by any means, but it's certainly an indication.
Richie, I was going to tell you that the study that Tracy was referencing was, we actually held a webinar yesterday at the center with Damon Greeley and one of his colleagues, and they actually studied some of the things that you were just talking about. So we'll get you a link to that webinar so you can listen to it, because it really is very interesting to see the impact of, you know, the protection around the patient, but as Tracy was mentioning, the actual, what happens to the infection to other parts of the room. And it was fascinating to see how the flow of the air really did make a difference in what was happening in the room. So we'll make sure that everybody from the Grainger CAN network gets a copy of that webinar, because I think you'll find it very, very interesting.
Thanks, Donna.
Damon Greeley and Jennifer Wagner. And
yes, that was the other.
They have fantastic, very good research.
Yeah, they've done some really good research, and they've actually, you know, published the work. So I think we'll make sure you get that. And Jim, did you get to finish your description of what you were suggesting that Richie do in the room? I wasn't sure if you actually finished your description of how
I know,
set up.
I know what he's talking about.
You do, okay.
Actually, Jim, our solution is to follow the TB guidance, which adds a construction type HEPA unit, a very clean one, of course, in inside the operating theater next to the bed, plugged in while the AGP aerosol generating procedure is being performed and turned off when it's finished. We did a smoke test on that. Positioning is important, but we did confirm that the smoke will be drawn right into the unit and filtered with the HEPA filter. But then back to the other conversation, then there's concern about the discharge with that turbulent air coming out and its potential to stir up any dust or anything that's laying about, you know, beyond outside of the surgical area.
Yeah, I don't know if
Jim, we can't hear you.
I think you might be muted.
You're muted now.
Now you're muted. You weren't muted before, and I don't know what happened.
No. Sometimes you can hit *6 and that'll unmute.
Hear me now?
Yes. Yeah.
Yes.
Okay, I'll ditch the high-tech device and just go with the low-tech one.
See what works.
What we've done in some ORs in Alabama is we did a temporary measure where we set up HEPA filters, connected them into the return grills to filter whatever was going back through the return air system. Was that necessary? It's a pretty low concentration of whatever's in there. I'm not sure it's necessary, but people feel better when we do that. And then we set up a temporary anteroom in the corridor, basically just blocked off the corridor with doors on both sides, set a HEPA filter in there to make that anteroom negative. And now what they're asking us to do is come up with a way to make that permanent without having to reconfigure the whole OR. And what we've come up with is just place some doors in the corridors that are normally held open so they don't obstruct anything. And when they want to, they can close these doors, turn on a HEPA filter system, and it all works. Again,
So, but then you're not covered on the back door with the sterile corridor, right?
These don't have a back door. These don't have a back door, so that makes it easier.
Yes. Because technically, if you put an anteroom on the front, you either seal off the back or you put an anteroom in the back, right?
Agreed. Yes.
Yeah.
If it matters, yes.
Well, that's what's up for debate, though, right?
Exactly. But I don't think we're going to solve that anytime soon. We're not going to know. And even if we know for a particular virus, what about the next one?
It should be virus irrelevant, right? Airborne virus, doesn't matter.
Well, infectiousness does matter.
I mean, what I'm saying, airborne particulate, that's nasty, whatever it is, even construction dust, right? It really doesn't matter, right? What matters is keeping it away from the patient and making sure that there's no adverse effect to that patient, right?
And no adverse effect to the rest of the world.
Yeah.
Yeah, you're after both of those. And we just assume that some of those nasties are a problem.
Right.
I see some new names on here, so I don't know if these are guests of some of the members, but I want to encourage you, if you have a question, to take advantage of our speakers, and don't be shy. I can, and I'm happy to just call on you if you want. I don't want to put anybody on the spot, but I want to make sure you have an opportunity to ask a question if you have any. Cher, how about you? Anything from your point of view?
I saw a hand go up.
I don't know if you can hear me or not.
Yeah. Yes.
Okay, I'm Cher Adler from Airborne VAC, and I'm sitting in on this call for Laura Marshall, and she wasn't available today. Our interest in all of this is, of course, the toilet plume with our vacuum systems. When you can purify the air in the rooms and all, and yet you still have a toilet plume that's infecting the environment for these patients or other areas of the hospital or in any other building. It becomes a very important thing to address, I think.
Yeah, Tracy.
And I had a good friend that was in the hospital for quite some time, and I noticed that when the nurses were coming and going from the room, that they would open the toilet room door to the patient room, and I told her to make sure it was closed. Like, you want that room to stay negative and contain whatever's going on in there. And I asked one of the nurses about it eventually. I was like, you guys are always going and opening that door. And she said, well, we've been told that that's better for everybody to keep that open and let the air flow through it or something. She's like, I don't really know. It's just kind of, that's what we were told. And I was like, oh, no, let me tell you what's happening here. And so we talked about it. And then I ended up visiting with the facilities folks because we do a fair bit of work at that hospital. And so I think you should send out some sort of notice, whatever your system is, to clinical staff to help educate them that the bathroom door should be kept closed as much as possible and not left open, because it is an issue. It's a concern. And in some areas, we're not allowed to put a lid on a toilet. It's prohibited. And I've asked for that to be changed. And so I think that the toilet plume is a source of contamination. I know on our infectious diseases subcommittee, when we talk about it, we brainstormed some ideas. There's one guy in the committee who did some rooms in an ER, and he went and put low wall exhaust down by in the toilet rooms instead of higher up. And he was collecting some data on that space to see if that would help. And, in some cases, the challenge is that sometimes that's beneficial and sometimes it might not be. And so, but there's certainly impacts that as a mechanical engineer, we run up against with the architectural layout of the space. You start putting in low wall exhaust and you're furring stuff out, affects the floor plan. That's a big issue with ante-rooms. And when you think about OR layouts, and if it does have a back door to sterile core and just the flow through the space. So it's important to keep that in mind. That's a challenge. But I think the toilet plume thing is pretty significant, and people are starting to pay a little bit more attention to it. We were aware of some of that with SARS, and then now with SARS-CoV-2, nobody seems to dispute that there's fecal contamination and that's a risk factor. I saw something recently where people were given advice, like when you go into a bathroom, a public restroom, like to wait outside, and then once you feel like it's clear, to go in, and which stall is the best one to go to. I don't know, when I go through the airport, I always have my suitcase with me and I leave it right outside the stall. I think if someone's going to steal it, I'll chase them down and, take it back, whatever. But I just leave it outside the stall, go in, do my thing. And then I have, my clean hand, my dirty hand, or whatever, like which one I open the stall lock with, because all of that's going to be contaminated. And which one you do everything with, and then wash up your hands at the end, and then I grab my suitcase. So I never touch my suitcase handle with like a dirty hand, and then if you have a wipe, you can sanitize that, because that's something that I think is gross and dirty. But I mean, I have hand sanitizer that's the spray kind, so I can spray the bottom of my shoes when I get back from the grocery store. And not everybody does that, so each his own, right?
Yeah.
Right.
I think
Tracy, you showed that slide with C. diff, right? The C. diff. Didn't you
Yep,
show
the
that
toilet.
slide that had the toilet, the Clostridium difficile, which is, very hard to eradicate in healthcare environment, is still being released from the toilet bowl. I can't remember how many flushes later, but, and over significant
24.
differences.
Yeah.
Right.
Yeah, I can share that real quick again.
Yeah, that's the important thing that Airborne VAC has to offer, is that they actually have testing showing that there is no toilet plume when you use a vacuum toilet system. So there are things we should be looking at in the future too, to eliminate the toilet plumes.
Yeah, I see Mr. Weeks. I don't see your first name. I saw you have.
Rodney.
Hi.
Rodney Weeks, and my question was answered on the slide. Thank you, Tracy. But the other question to follow that was, is there a time frame? I noticed you have a plexiglass simulating a lid. So was there a time frame of how long the aerosols are airborne?
Well, that depends on the RH.
Oh,
Sorry, go ahead.
well, yeah. So no, I don't recall that they had. I think they were just performing those studies, and they didn't wait to see like if after a certain amount of time it was dissipating. But I know that the ventilation rate in bathrooms is prescribed by code as a minimum level, and I haven't seen like good, PCR type analysis, but we've had places where we've ventilated those bathrooms to a higher level and had just more anecdotal positive evidence about it. I mean, one of the things I just find is just acoustical. We try to make our HVAC systems quiet, but when you have bathrooms and exhaust fans, not that you want them to be loud and annoying, but if they're really quiet, people don't think that they're working. And so having a little bit of sound associated with it isn't necessarily a bad thing. But I know that that is persistent for some time in the air with that toilet plume. And yeah, Steph, you're right. If I don't know, maybe it'd be better in a bathroom because you've got all this moisture going on that maybe the relative humidity in a bathroom's a little better, but maybe not. That definitely has an impact though on the aerosolization of those droplets and whether or not they're going to be small and float around or whether or not they're going to be wet. When I think about the relative humidity piece, I think about if I were going to dust my house and I wasn't going to use any pledge and I was just going to take the cloth and just wipe stuff down and it's just going to billow around everywhere, versus if I have pledge and I add some moisture and I can wipe things up. And when we're doing all our cleaning and disinfection, there's a minimum contact time for those products to be effective. And I think if the air is really dry, that could evaporate more quickly and be less effective.
And as long as we're talking about bathrooms, we're also learning that those hot air dryers, that you put your hands under, are actually disseminating, anything you might not have washed off your hands. And if that includes like a pathogenic E. coli or C. diff, that the counts under those hot air blowers are high. And so actually using a paper towel or a rotating cloth is a better option.
Okay.
As long as we're in the bathroom.
Yeah, and then you're trying to figure out your hearing protection too when you use those air ones.
Paranoid's coming out, like big time. I want to just check with Edgard and Anne, just to see if you have a question.
Hi, this is Anne. Can you hear me?
Yes.
Yep.
Actually, I'm with Morris Group International, so I'm in one of the other divisions that would be a sister company with Cher. So I kept looking at Cher's name thinking, why does that name look so familiar? But anyhow, I received the invite from my boss, who suggested that I attend. Vince Conti, that name might sound familiar to someone here. But I actually work with Grainger. So we provide the Whitehall Best Care ligature resistant products to Grainger. And so that's why it was suggested that I attend. I have no questions. It's been incredibly informative. And a lot of the things that you're saying, I think I've been instinctively right about the things not to do with hand dryers. And also I'm very big on the humidity in a house or a building.
Great. I'm just checking. Edgard, anything from you, or Sin One? I don't know who that is.
So I'll just speak up while people decide if they have a question, but I live in northern Vermont, where I'm not visiting my brother. And in the wintertime, it gets, 15 degrees below zero. And finally, about 4 years ago, my husband, who's got some lung issues from being in the military, and I decided that it was time to humidify our house. So we use a combination of steam and evaporative, because we also have a wood stove and radiant heating. And in the 4 years since we've been maintaining our humidity, sometimes it's only, you know, over 30 when it's super cold outside, because we're in an old farmhouse with some infiltration. And but he has not been, and this isn't statistically significant, but he has not had a single cold in the 4 years, and neither have I, that we've been humidifying. And you know, our guitars stay in tune, and we can pet our 7 dogs and you don't shock them. And you know, it's really been, I can't believe it took me that long to actually implement this, but it's been such a great intervention for us.
Interesting, very interesting. Abby, any questions from you?
Yeah, I had a question for Walt from the beginning. Is he still on with us?
Walt, are you there?
You're not going to believe this, but I'm on 2 meetings at once, but I'm
Oh no. I'm sorry to bother you.
No, it's good.
You know, I was wondering about the paper that's the rewrite that you're publishing, and curious about the risk-based strategy, and is what's changing the evaluation, so the framework of the risk, or is it part the tools or potential recommendations? So what are the changes?
How do I want to answer that question? You know, I believe increasingly that when we write code, we are essentially performing a risk-based, a risk assessment on behalf of everyone in a way, and deciding that certain things are risky enough that we're going to require intervention across the board, even though that's probably not always needed in all circumstances, but we're going to say it's risky enough. So I think codes are inherently a form of risk management. The position document that we're writing is different in that we are not necessarily saying this is the intervention somebody should undertake. Instead, I think what we're trying to do is to say, and let me see if I can try to give you an example. Often we will have studies that say, well, a virus dies more quickly if it's sitting on copper than if it's sitting on something else. Okay, so from that, we might leap to the conclusion that all high-touch surfaces ought to be copper. But we don't really know if that requirement would make a difference in outcomes. We're reasoning from something that we know to something that we're deducing, if you will. So for the paper that we're writing, I think what we're trying to do is to better summarize what we know, what we really know, and what are the logical conclusions that you might draw from that, that in a way that we hope will be helpful for the people who then say, all right, well, if I'm writing a code around anterooms in an AII situation, what is the real science that's helpful to me in making those decisions? Or if I'm a clinician trying to decide what's the best thing to do, what do we really know? And so I think what we're trying to do is summarize the science. And actually on my committee, I actually have a risk management professional who ran risk management for the VA for many years. So very familiar with the idea of how you take ideas of risk and translate them into policy or usability in different frameworks. So that's what we're trying to do in the position document. And then to some degree will be to others to take that and turn it into concrete, actionable steps. I think we're going to try to point out where we think something is well enough known that it probably ought to be code, or conjectural enough that maybe it's a best practice kind of a thing. So we'll do our best to sort in that way, I think.
Got it.
Does that help?
It does. It does. And I understand that, you know, that this isn't an easy answer. I'm from Grainger, and we get questions around, or we are trying to lead with a risk-based assessment. We have a band of safety specialists, obviously from the MRO perspective, and ultimately we're trying to guide customers to sort of those non-negotiables. But there's so much fluidity in this situation, and so anyhow, no, this has been very interesting, and I'm learning a lot. So thank you to all of you and your expertise.
Richie, do you have a question?
I'd like to add a little bit on the that comment with the risk assessment. I think it's good to be doing that, and I don't have an objection about it, but I want to suggest something, a broader thought, and that is that when we look at risk assessments, we're looking all the time about how often things happen. And it goes back to that comment of, like with the Fukushima reactor, what didn't we imagine? What didn't we think of? What exceeds what our experience tells us can be? And that happens very often. Those books you've probably read, the Black Swan and Fooled by Randomness, and those books talk about doing things to help make us more resilient, so that when something negative happens, it doesn't destroy us, but it can actually make us stronger. And how do you design HVAC systems with that in mind? I've been thinking about that ever since I read that book years ago and trying to come up with stuff. But one thing that I do know is that having some options and some flexibility makes a big difference, because we don't always know what we're up against. We don't know the way that next virus is going to manifest. I mean, we're starting to think that SARS-CoV-2 creates this illness, COVID-19, that has a whole lot to do with our cardiovascular system. I saw a note the other day, a friend of a friend that's got somebody who is a young guy, and he just had a stroke, and now he's tested positive for COVID. And they said, gosh, now we learned that that's a symptom of that. And I thought, I feel very bad for him, and I'm keeping him in my prayers. I also thought, oh, doesn't everybody know that? I mean, that's been out in the news for a long time. Like, these things are going on where diseases are different than what we necessarily imagine at the beginning. And you read that book that I put up at the beginning, Spillover by David Quammen. He talks, and he's a great writer because he can make the story interesting while he shares the technical knowledge as well. Just talking about the wide variety of illnesses. And there's another book that I should grab and share with you. Think about, if you haven't read it yet, is The 5 Days at Memorial. It's about after Hurricane Katrina and how facilities dealt with it. And of course, you can see the way I read a book is with lots of tabs and underlining and things. But there was a facilities person at Memorial who looked at issues that could be of a concern well in advance and tried to get his facility to do something about it. And his name was Yankovic, and he said, like in here in this book, he concluded in a memo, I'll keep it on file for future consideration. And this was trying to get their backup generator located up above grade so that it wouldn't flood. And, that generator is only as good as its weakest link. And I actually, after I read this book and looked at the warning flags that he threw up and the things he tried to do in the facility to make it better, I went and looked to see if I could find him. And he's moved to another hospital. And the way I found him Googling on the internet was an article about some of the stuff that he was doing at the new facility to help make this other place where he's at now more resilient and more robust. And so I thought, gosh, hats off to him. He went through something horrible where he said, hey, let's do these things, and people ignored him. And then it ended up just being awful and lives were lost. And he's moved on, and he hasn't stopped. He hasn't stopped fighting for what needs to happen. He's making improvements. He was soliciting funding for other projects. And sometimes just being able to share a story with somebody about a real event can make a lot of difference when you're trying to persuade them to do something. Like sometimes I'll suggest to the client, hey, maybe you might consider doing this instead. This could be a problem. And it doesn't always carry as much weight as if I can say, I had another project where a client did this and here's where it went wrong. And then they're like, oh yeah, we don't want to be like them. And so then they listen to that advice. But if you just say, well, this is what I'm thinking, and you look like you're, I mean, I don't wear pigtails, but I look a lot younger than I really am. And I ran into that early in my career too, of just trying to give people good solid advice and letting them think, where are they on that risk spectrum? I think people have to think about, where does the public expect you to be on the risk spectrum? Where do your patients and where do your employees expect you to be, and to be true to that? So this book may give you some good ideas or some good stories that maybe aren't your own, but that you could kind of make part of your own when you're making the case to your administrative staffs that you need some funding to make things right.
Thank you.
I was going to ask you, you had, and I don't know if you solved your question about your ambulatory facilities question, but I wondered if you wanted to ask Jim and Tracy for their opinion about that.
You directing that to me, Donna?
Yeah.
I'm sorry, I missed that. Yeah, I think we have it straightened out. So what we were doing was evaluating our ambulatory spaces in our medical office buildings to determine appropriateness for rehabilitation by both the staff and the patients, and finding a safe environment. We've, to make it simple, we've put in physical barriers. We've adjusted seating arrangements, and in places where we're doing aerosol generated procedures, put in mechanical precautions, either ceiling mounted HEPA units or portable HEPA units with snorkels on them, particularly in the dental clinic area, to remove those nasty particulates from the area, and or clean and scrub the environment in a faster manner, allowing us to turn the room over faster. So that's what Donna's referring to.
Does that make sense, Tracy?
Yeah, it makes a lot of sense. I agree. And I think, one of the things we're looking at in our infectious diseases subcommittee group is how more sick, more acutely ill people are coming to places that are not the main central hospital. And what should we be doing? Should we be changing standards or requirements because of that? And you certainly run into that with ambulatory facilities. I think even more so with urgent care, or a little dock in the box in the strip mall, that we have people saying, showing up at those when we've had measles outbreaks, and those areas have not been designed to deal with that the same way that it is if you walk into the emergency department and you have measles. At least you have 100% exhaust going in there in the waiting room. And do we need to look at making changes to the requirements? Because part of the benefit of having those urgent care centers close to people is that it's a lower cost venue. But when I've talked to a lot of different places about why they're doing that, it's to bring the care closer to people and to provide a better experience for the individual and better access to healthcare than having to come to the big medical center and trying to wayfind and park. That having these satellite places is more convenient, and not as much for the cost savings, although that is a factor. But maybe we should be requiring that all of those waiting rooms get exhausted. Looking at that.
So, okay. Really? So exhausting that's a new thing, right? Exhausting the waiting rooms?
Yeah, exhaust the waiting area, even in an urgent care clinic. 100% exhaust, just like you would in ED.
That's a consideration, Donna. That's not in code yet, so
Okay.
don't get too excited.
Yeah, that's the first time
But if you talk to a person that goes to a place like that, and you just have a conversation with 5 friends that that aren't really in healthcare, and say, when you go into an emergency department, the waiting room is 100% exhaust because someone could come in that's infectious. Do you think they do that at an urgent care clinic? I don't know, maybe it matters how you word the question, but most people will say, well, yeah, it's the same kind of thing, right? You're going to be sick and you're going to walk in there and no, it's recirculated most of the time.
Yeah, yeah. Well, I think you're right. I think the ambulatory facilities are, you know, everybody talks a lot about the hospitals, but ambulatory care has really got some pretty significant increase in the acuity of the people that they take care of, and certainly now with COVID and any other type of infection, I think that's where people are going. So being cognizant and thoughtful about what that environment looks like, I think is probably the next thing. And I don't know, is ASHRAE looking at all environments, Walt and Tracy and Stephanie, when you're doing your review? Are you looking at it all?
We are. I mean, we're looking, and in fact, one of the criticisms of the position document was that it was too healthcare centric. They want us to focus on all spaces. And I think we did it, but we had a heavy preponderance of healthcare people. And so we have to be careful to make sure that we are thinking about all occupancies.
Okay.
Yeah, and I know like the epidemic task force we have subgroups. I'm the healthcare team lead, but we have people looking at residential. We just added a new group for industrial facilities. We've got a group for transportation. There's commercial buildings. There's schools and universities. So each space is getting its own consideration. But the nice thing is that we're sharing information overall as a task force and reviewing each other's content to make sure that the guidance that we're giving is consistent and that it's, you know, not only tailored for the kind of facility, but then we're learning, oh, someone over here found a research paper about something, and Stephanie's been really great about sharing a lot of information. So we're trying to make that apply to other places. And then we've had other requests from people to add even more areas. We're going to do a specialty thing for dental clinics, a specialty thing for residential healthcare facilities, because we know we've had so many deaths in that kind of place. And people have asked us if we're going to do something for restaurants or for, trying to think of what the other one, fitness centers, that kind of thing too. So.
Okay, great. Well, I think unless there's any other questions, I think we'll go ahead and wrap up. Do Walt and Tracy and Dr. Taylor, do you have any final comments you want to make?
Only that you should be calling me Stephanie.
Okay. I didn't know. Any final comments?
Just appreciate people's time. I think those folks tuning in really show they're at the forefront of doing the right thing for their facilities and in their jobs. And so I commend you for doing that and taking the time to be here, and just encourage you again, if you have questions, to reach out to us and seek answers. Keep the dialogue going.
Yeah, that's great.
And I just want to say thank you very much for letting me participate. And I would encourage everyone to, you know, think about the idea of using health as a metric in your buildings. And I would think that engineers, architects, facility managers are going to need to learn medicine, because I can tell you, physicians, we're so stubborn and stuck in our own rut that most of us aren't going to learn a lot about buildings. So I think the onus is on, I mean, you guys are always thinking, you're thinking creatively and proactively, and I would encourage you to include medical information in your knowledge base.
Great.
Yeah, be careful. Pretty soon Stephanie starts sending you books like this, which was really educational, but a lot of Googling terms during that.
Yeah, if you send Tracy a book, you can pretty much be sure she's going to read it and underline it.
You know. Jim, sorry, I didn't ask you if you had any final comments. And then we'll finish up with you.
I just want to
thank you all very much.
I think there's a lot of, there's so much interesting conversation happening in all of this. And I think it is going to change the way we design buildings, especially hospitals. but probably a lot of other buildings too. Hospitals already have a lot of ventilation going on. But at any time you have a crisis, there's a risk of swinging too far. You know, we've already been through a cycle where we went too far in one direction, right? The oil crisis in the 70s, and ventilation got cut way down, and we saw that there was a problem. And so ventilation goes way back up. And I think we see some of that. There certainly is the potential. We could say everything has to be 100% outside air and lots of air changes and all that. And that might help, but it might cause other problems too. Energy is going to be a big issue in all this. And if we drive our energy usage up, then we're creating other health problems. So I think we all need to learn what we can from this, but step back, take a breath of clean air, and and think about what the real long-term issues are in our buildings.
Yeah, Tracy's sensitized me or made me open my eyes to the whole concept of unintended consequences. And I was flying to Richmond, where I am now, from Vermont, and first time at an airport in 4 months, and all of the I realized all the drinking fountains in the airport are shut down. And in Boston anyway, there were hardly any places you could even buy water. And when you get on the airplane, all they give you is one teeny tiny container, like a 6-ounce container of water. And I thought, okay, so they're trying to prevent, you know, transmission through drinking fountains. But meanwhile, everyone who was already dehydrated is even more dehydrated.
Right.
And talking about unintended consequence, that's like the worst thing you could do to people.
Right. Right. Exactly. All right. Walt, you want to have the final?
Oh my gosh, the final word. Well,
Don't
this one,
mess it
the
up.
final word. Maybe I'll just
No pressure.
Yeah, but a couple of other thoughts about ventilation. And here, you know, I sometimes wonder, just in full disclosure, I'm not a ventilation engineer. I'm an electrical engineer. And I often ask myself, who am I and why am I here in some respects? And, you know, my rationalization is, well, I've been to law school, so I've been trained in evidence and how to apply evidence to important questions. And so maybe that's a value that a perspective I can bring. But, you know, and Tracy and I have had, I'm not going to call it disagreements, but certainly we've had honest conversations where I sometimes wonder, there's a saying that to the person with a hammer, everything looks like a nail. And I sometimes, to sort of echo a little bit of what Jim said, you know, although we can imagine lots of worst cases, and we can try to put in place lots of measures to prevent lots of worst cases, I do wonder sometimes about the wisdom of that. And I'll just leave you with 2 final stories to sort of illustrate that point, because I think these are hard questions. I don't think they're black and white. I think they're complex. I talked about the Legionella standard a little bit and crafting that. And when that document was first released by ASHRAE, it was very prescriptive and very, I'm going to call it heavy-handed. And one of the criticisms from the healthcare community, and this was from, frankly, APIC, the infection control professionals, as well as from ASHE, was that the document, by focusing so much attention on one threat, that in the scheme of threats was relatively small. It prevented the use, how do I want to say this? If there's an assumption that an organization like a healthcare organization is resource constrained, if we throw too much resource at a problem that maybe is a smaller problem relative to other things, it prevents us from spending resources we might need elsewhere. And I hear people in the codes world say, my gosh, if we can save one life with this intervention, then we have to do it. And I resonate with that, you know, if it were my life or my child's life or whatever, right? But at the same time, I think we do have to, Stephanie, you use the word unintended consequences, right? I do think we have to be aware of context of every decision we make, and not that any decision is right or wrong or anything is right or wrong, but there are trade-offs often, and I think we have to be aware of the trade-offs that an intervention might make. And the second related point, I was talking to somebody the other day, he's an epidemiologist at the Centers for Disease Control, and he was saying, listen, we can ventilate like crazy, or we could wear a mask, right? Maybe we should focus on things, simpler interventions, and not try to make ventilation the solution to every problem. And so, you know, again, I don't think there's a right or wrong. I don't think there's an absolute here, but I do think there are important, important things in terms of context in our decision making, which is why sometimes I think risk assessment is a carefully and well-performed risk assessment is a great tool to use rather than sort of broad sweeping policy for dealing with complex situations. So maybe that's all I'll say.
Great. All
I
right.
hope that was a decent last word.
It's good. It was, I think.
Yes.
Well, thank you again, everybody. Have a great weekend, and we'll hopefully see all of you again soon. All right.
Thank you very much.
Thank you so much.
Thank you.
Bye-bye.